From a personalised healthcare perspective, which is a key part of the Roche Group strategy, and Deborah referred to it in her presentation. Clearly, as more and more targeted therapies make their way to the market, and there will be an increasing number of new diagnostic assays, algorithms, which in tandem with these targeted therapies have the potential to make a huge difference to improving health, saving lives, and delivering efficiencies across healthcare services.
Pathology practice has no choice but to be progressive and responsive. It's at the heart of all medicine, so there's no alternative. We have to deal with that. And it's for patients, it's not for budgets. And I think sometimes it's as hard to convince one's clinical colleagues in pathology that that's the case as it is to convince managers. It has not helped to have a political divide between clinicians and managers in the National Health Service. It has not helped for each side to be throwing half bricks at each other. That has been disruptive and destructive. And we need to stop doing that and start talking to each other more rationally and more intelligently. I would make one exception to that plea, and that is that we are having great difficulty discussing with the Foundation Trust Network the possibility of having our advice accepted about what's a doable job. And if pathology is going to be progressive and responsive, then I'm sorry, but the imagined freedoms of the Foundation Trust Chief Executive have to be swept away, and they have to understand that these freedoms are as limited as ours. We need that dialogue, and if anyone can help persuade the FTN board to let me come and talk to them, I'd be very grateful.
Pathology has seen an enormous amount of change. I mean, if you just look at the last 15 years, there's been a revolution in numbers, in opportunity, in design, but very little of those things were driven primarily by pathology services, and often they were following changes or events that had happened elsewhere in the service. And perhaps that's inevitable given the role of pathology in health services. Drivers for change generally are at the sharp end of practice, especially specialised services. For example, the increasing focus on targeted treatments in cancer and other fields means that the precision of diagnosis now becomes molecular rather than anatomical, for example. Of course, we are to blame as well. NICE's guidance has expanded to the point where none of us actually know what it is anymore. And there was a time when I could remember all of the guidance that NICE had produced. But now with 1,400 volumes, it's just getting too difficult, not only for us to coordinate it, but for the service to implement it. So guidance is a driver for change, but also part of the problem.
One of the two biggest things on our minds as an industry at the moment is how do we actually get products into the NHS? How do we get past the point and into adoption? And there are a great number of initiatives to get products to the point of adoption. And we've rehearsed these with government, with the Ministerial Medical Technology Strategy Group, which meets twice a year with ministers Earl Howe and David Willits from the business department. But we always come to the same thing. Everything gets us to the top of the hill, but nothing actually pushes us over the brow of the hill. So what can we do to change that? Some of the great initiatives have come through NICE with the creation of the medical technologies and diagnostics assessment programs. So there's an HTA program for diagnostics. There's a simpler program for diagnostics that don't need a full HTA. And now there are medical innovation briefings that are products NICE are newly producing, which are not evaluations at all, but they're a quick sanity check of what manufacturers say a product can do, and putting information out there so that perhaps that will get adopted more quickly. People will take the risk. In specialised services commissioning now, there's the commissioning for evaluation programme, where if you have got a new technology that really looks like it will be game-changing and improve efficiencies and outcomes, then there would be an opportunity to get that brought in almost like a pilot in some areas to have real-time evaluation. So there's There's an awful lot that's going on.
One of the famous bowel cancer biomarkers, of course, is the KRAS biomarker test linked with the Merck Serono drug Erbitux. And there are others in development. What impact on pathology services? Well, there needs to be enough capacity again, as there's this increasing move towards targeted therapies for pathology to be able to detect biomarkers. And I think certainly what our pathology colleagues are telling us is very much that there needs to be adequate funding for testing, identified when the drug is considered for approval. There can't be pump priming from the pharmaceutical companies only to withdraw when the drug is out there. That needs to be sustained.
In any large institution, whether it's the public sector or the private sector, change is always a challenge. There can be a reluctance to accept that there's a different way of doing things. There may be the question that, well, actually, we're very effective now. We couldn't do it better. So how could it be better if we change? Or to perhaps paraphrase Henry Ford, if I asked pathology what they wanted, they'd have said a faster status quo. We all know about the financial constraints. Yeah, a lot of talk around Carter, up to £500 million per annum. That's not cost improvement programme savings, that's cash in hand, please, and your cost improvement on top of it. But I think what people forget is that in the report, there were 20 recommendations. Consolidation is mentioned first at number 8, and the first 7 have a lot to do with quality. I think there's also a question of trust. You know, it is easy to deliver results of U&E and creatinine. It is. And this is a direct quote from that report. Everyone we have spoken to acknowledges that driving up standards, quality and patient safety. Anybody disagree with that? No, good. At the same time as reducing costs between 250 and 500 million pounds a year. Anybody disagree with that? Good. Unfortunately, Fred the Shred has put paid to the next bit of the statement, so, you know. But actually, have we delivered it? I'll just leave that thought hanging.
The nature of pathology is changing fundamentally, just as the needs of the population are, and the organisation of pathology care has to change as well.
I think there's a lot of confusion in terms of the direction of travel, where we're actually going, and it's a case of what are the important issues and trying to understand from other people what those are.
I think it's very important that anyone with a vested interest in the success of pathology services has to meet. We have to talk. We need more dialogue than we've had in the past. I think some of the reasons why commissioning has gone offline is because we haven't had enough conversations such as is happening today.
If the industry engage with CCGs at a level that is helping to solve problems and find technical solutions for issues that they've got, that's the basis for a good discussion.
I think this event is always important when you've got a wide variety of people coming in and telling us about their experiences, what's going on.
I think it's really brilliant of them to do this, to provide a day event like this with such good speakers who've got a lot of experience that they can talk about and hopefully we'll learn something from.
The partnership between the HSJ and Roche is really important. It's a good way of provoking debate and has certainly today shown the need for clear strategy and leadership within this area.
HSJ is the go-to journal for anyone interested in healthcare policy in the UK, and Roche, being one of the market leaders for the IVD industry, have got a keen interest in making sure that they shape the environment for the industry.
The IBMS has no blood science specialist portfolio for biomedical scientists, and the Royal College of Pathology has no qualification in blood sciences. You're either a clinical biochemist or you're a haematologist. And I think a lot of those things have not been addressed in all these proposed reconfigurations, which to me are driven largely by cost and without really adequate consideration of the impact on patients.
I think pathologists have been too nice. And I think pathology departments have been delivering 5% CRES savings year on year, and yet people then thrust upon you Carter and you can make even more savings. And I think you're already down to the bone already. The other thing I would say to you about the future of pathology is that you need to get out there more often. And I think if there's one thing I've learned from my experience as a commissioner, is that all the patient benefits come from clinical engagement between primary and secondary care, the redevelopment of pathways, the appropriate use of pathology, and that comes largely from clinical engagement. More and more I look at pathology, I am less and less worried about the labs. I am less and less worried about where my work is done. All your laboratories meet CPA accreditation, all of them are of a high quality, the variability and error in your laboratories is minimal. All the errors, all the cock-ups occur pre-analytically. And that's why we focus very much on that pre-analytical phase and also the clinical engagement. So in the service specification I've just drawn up for all service providers, the clinical imperative is the most important part.
I strongly believe that for point of care in the community, you need to involve the labs to make sure that you have proper quality control, etc. That they go check the machines, etc. And they can work with the GPs in the community and in the hospitals. And modern point of care machines can be interfaced to the lab system, so you can still get them in the patient records, etc. So for the use of technology, you can move away from some of the problems.
There's been some mention already about innovation, and I think that really does require us to be phasing out tests that don't work or that have been replaced with more effective tests and reinvesting that money back into the later technologies. And I think what's really critical, and I think there's been some mention it today, that actually there needs real clarity of strategy. We're in a quite frankly, we feel like we're in a bit of a mess with a lot of unclear strategy between some of the new organisations. And I think there needs to be central leadership, but ensuring that it's delivered effectively and that that's actually followed up and is delivered consistently so that we don't have the same levels of variation. I think certainly in terms of bowel cancer, we'd save a lot more lives if we had less variation in different areas of the UK, both at every stage of the patient pathway.
Well, look at Europe, countries where they have had consolidation, Germany, Spain, and really the government intervention has been to introduce a tariff, to progressively reduce that tariff, and to kind of let them all, and to give GPs a choice of where they want to send their tests so that people are competing on quality, not price, and to kind of let the market work it out. Is it time to sort of stop playing around at top-down intervention and just kind of let the market rip a bit?
When we read the secondary legislation that led to the involvement of the OFT and the Mergers and Monopolies Commission into this business, we, the college, thought that would mean that there'd be some control over wayward local commissioning and provision of pathology services. We didn't expect to see the lawyers tearing up what looked like viable amalgamations and letting some through that is really quite astonishing. I'm not going to name which is which, but the OFT has made two recent decisions which I find extraordinary. One in which it's approved a joint venture partnership, which frankly should not have been approved in my view. And the other is that it's stopped an amalgamation in another centre where it's quite obvious that two departments, at least two pathology departments, if not two old trusts, should merge. So I'm not quite clear why OFT and MMC have been given these powers. I don't think it actually fits with what the legislation said.
Pathologists are more likely to have experience of leading things than the average clinician. So they're as well placed as anyone is to do that. But the community they have to lead is much broader than that of most clinical departments, because it extends not only beyond their specialty, but beyond the hospital. And as we've seen, some of the hinterlands of big pathology labs are massive. So it's the leadership in pathology is a serious role that needs to be taken equally seriously by customer organisations as well as their employers.
How services develop in terms of their delivery is going to change, and we've got to adapt to that. We want the best qualified people, the people who've got the right competencies in the right place. But I think it is going to look very different to how it's looked in the past.
Can I thank you all very much for coming and contributing so fully and interestingly to the debate. Thank you very much and good night. I think the HSJ Pathology Conference is one of the few times in the year where you can actually come and debate those challenges, explore the opportunities, understand the threats, not only with your peers, but also with the leaders of the pathology service as well.
It's been a brilliant event. I'll certainly try and come again next year.